respected panelists and all the delegates. Building upon the discussion and the cases that are done by Dr. Shiva, I would like to have a discussion on the medium vessel occlusions. These are the small vessels, but they are raising big questions, and especially with the latest trial results, MEVO has become a central focus of discussion. Already, Sailaja ma'am had made some brief comments on this MEVO, so making my presentation easy. Thank you, ma'am. So this is our agenda for the today's topic. I'll start with the definition of the medium vessel occlusions, followed by the current evidence. I'll speak about the recent RCTs that are published and a meta-analysis that was done by me and my colleague. But it is in the preprint, but it is still yet to undergo the peer review. Followed by I'll discuss about the limitations and the future directions of these medium vessel occlusions. So whenever we talk about the medium vessel occlusions, one of the first challenge that is it lack a uniform definition like that of large vessel occlusions. Broadly, we speak that the medium vessel occlusions are beyond M1 and beyond basilar artery, but there are a lot of variations in this. So the key two anatomical features that define medium vessel occlusion is first the vessel distance and its tortuosity, and the second being the size. Inherently, these distal vessel occlusions or distal vessels are longer distances and they are more tortuous with a more branching compared to the large vessel occlusions, and they are of size 0.75 mm to 2 mm, whereas the large vessels are more than 2 mm, whereas the small perforators are less than 0.5 mm. So these are the main two characteristics that define the distal vessels. On the left side, we can see these are the large vessels which we are familiar with, that is ICA, M1, MCA, basilar and the vertebral artery. Whereas on the left side, we can see the true distal medium vessels, that is M3, M4, MCA, P2, P5, PCA and A2 to A5, ACA, and the posterior inferior, anterior inferior and superior cerebellar arteries. But there lies the gray zone. That is M2 MCA, P1 PCA and A1 ACA. There are some distal medium vessel occlusion trials that involve these, whereas there are some trials which excluded them. So the major problem lies with the M2 MCA. So it is better to differentiate these M2 MCAs based upon their particular size and the distalness of the involved M2 MCA rather than taking them as a common entity. If you consider in that way, the M2 MCA, particularly the proximal and dominant M2 MCA, will be considered better to consider into the large vessel occlusions rather than including them into the medium vessel occlusions. So when we look into the burden of the medium vessel occlusions, they account for nearly 25 to 40% of all the ischemic strokes, and the most common location being the M3, that is contributing around 60% of all the medium vessel occlusions, followed by M2, which is contributing 22% of all the medium vessel occlusions, and this is followed by the PCA and the ACA territories. So despite the thrombolysis, one-third are failing to achieve functional independence despite of these thrombolysis, and also there is a suboptimal recanalizations reported, that is less than 50% after IVT. So with this one thing is clear, that the medium vessel occlusions are common, but the outcomes with the IVT is suboptimal, and also these medium vessel occlusions are underrepresented in the early EVT trials. We don't have much data on their thrombectomy outcomes. So that is why this is the point of discussion these days. So what does the evidence say? This is the first meta-analysis published by the Bijoy K. Meena et al. This is the first evidence of all the RCTs from the Hermes collaboration. In this data set, we have 130 patients, but to emphasize, all these occlusions are M2 MCA occlusions, and out of these 90% are of proximal M2 occlusions. And here we have a benefit of EVT. The odds ratio is 2.39 with a significant p-value. And surprisingly, the symptomatic ICH, there are no symptomatic ICH reported in the EVT group when compared to the best medical management group. So one thing is clear here, these M2 MCA occlusions, especially proximal M2 occlusions, achieve better functional outcomes with a lower symptomatic ICH. But we were not able to translate these results to the distal medium vessel occlusions because the M2 proximal were considered more of larger rather than the medium vessel occlusion. Let's see whether our guidelines helps. Currently, the American Heart Association and Stroke Association 2019 guidelines tells more about M2 occlusions, that is within 6 hours, and they mention that carefully selected patients. This is class 2A, class 2B recommendation, whereas the ESO 2023 also commenting only about M2 occlusions. But there is insufficient data for the true distal occlusions currently. So let's see whether further evidence helps. 2025 has been a landmark year for the medium vessel occlusions because there are 3 major RCTs that are published in 2025. I call them as 3 giants of 2025 as of now. So there are Escape MEVO trial, distals, and the discount trial. All these were published this year. First trial, that is Escape MEVO trial, was published by Goyal et al. And this trial with a sample size of 530 patients, but this is the only trial which included the proximal M2 occlusions also, constituting around 25%, whereas the other 2 trials didn't include the proximal and the dominant M2 occlusions. The second trial is from the Europe. The sample size is 543 in this. This excluded dominant M2 occlusions. And the third trial is discount trial from the French population. The proposed sample size was 500. However, it is early terminated because of the futility, and the total sample size here is 152. And this trial also excluded the proximal M2 occlusions. So let's synthesize the data from these 3 major trials. We have done a systematic review and meta-analysis for all the RCTs on the medium vessel occlusion. So we found these are the only 3 randomized controlled trials that were exclusively on the distal medium vessel occlusions. And we can see that all the point estimates of these 3 trials, distal, escape, MEVO, discount, all were crossing the null point. Even the effect size is also crossing the null point with an odds ratio of 0.82, which is not significant. And coming to the excellent functional outcomes of MRS 0 to 1, we have outcomes of this MRS 0 to 1 in only the 2 trials, that is distal and escape MEVO. In both these trials, we can see the point estimate is crossing the midline and the effect size is also crossing the midline with an odds ratio of 0.91. So with this, it is clear that there is no significant difference in the functional outcomes at 90 days in these 3 trials. So let's see about the safety of these trials. Symptomatic ICH is reported in all the 3 cases. We can see that the point estimate is towards the intervention. Even the effect size is also favoring the intervention with the odds ratio of 2.33. That is, there were 2 times high risk of symptomatic ICH in patients with the medium vessel occlusion undergoing endovascular therapy when compared to the best medical management. However, it is not translating into the mortality. If we can see the mortality, the odds ratio is 1.3, but the confidence interval is ranging from 0.9 to 1.98. That is, it is crossing the null point with an statistically non-significant p-value. So there is a 2-fold increase in the symptomatic ICH risk in patients with the EVT. However, all-cause mortality did not differ between the groups. So where are we now? So there is a signal of safety, but the efficacy is not yet established from these trials. But is the story over? Let's see what are the limitations that were happening in these trials and what is the future perspective. So the first limitation of these MEVO trials is they have reported a recanalization rates of 71 to 75%, which are modest when you compare to the early large vessel occlusion trials where they have reported around 80 to 90% of the recanalization rates. And also it is not uncommon that you have a short of catheter lengths, because all the catheters that are used with the large vessel occlusions and also the stent retrievers, it is difficult to use those large vessel occlusion stent retrievers because with these small vessels, they are harder to navigate through these small tortuous arteries, leading to more technical difficulties and procedural risk. For example, when you keep a stent retriever in a small vessel and if you have withdrawn, this results into the straightening of these small vessels and leading to the damage of the perforators, leading to the high risk of subarachnoid hemorrhage or any procedural risk. This is also translated in the high percentage of symptomatic ICH in our meta-analysis also. So there are high procedural difficulties and complications, and also there are workflow issues. So when you compare with the onset to reperfusion time in case of large vessel occlusions, the distal medium vessel occlusion trials have taken a longer time. It's around 1 to 2 hours more than that of the early large vessel occlusion trials. So mostly the delay happened because of the difficulty in recognizing the distal medium vessel occlusions on the imaging, and second, because of the difficult navigation, even the puncture to recanalization times are also higher in case of these distal medium vessel occlusions. So apart from these, beyond the device and the workflow, there are intrinsic biological limitations in case of distal medium vessel occlusion strokes, where the distal arteries supply the smaller territories with a limited collateral. So even successful reperfusion may not translate into a big clinical gain. And many patients in these trials also have a milder strokes. For example, in the distals, they have included around 40% of the patients have NIHs of less than 5. And the mean age is also higher when compared to the LVO trials. The mean age is around 70 to 75 years. So these all things are limiting the marginal benefit that is expected from these trials. So how to overcome this? We all know that one size doesn't fit all. So we need to have a tailored approaches for the distal versus proximal vessel occlusions. So device innovations, particularly small caliber aspiration catheters, mini stent retrievers for these tortuous anatomy and safer navigation, efficient clot removal is much needed. And also imaging innovations are needed because there was a long delay in the workflows. We need to have automated distal medium vessel occlusion detections on the CT angio, which may help in order to cut out this time. So my take-home message is, do not classify the proximal and the dominant M2s as distal medial vessel occlusions, because majority of the distal medial occlusion trials has excluded them. And the MEVO thrombectomy, as of now, with the current evidence, it is safe, but it is not having a consistent efficacy signal. And as of now, distal thrombectomy is not a default care, but decisions should be individualized depending upon the patient condition. Future progress requires better devices, faster workflows, and a smarter patient selection. Thank you. I request panelists for the discussion.
One question at the most, ma'am. We are running well behind.
Yes. No, first of all, congratulations on a fantastic presentation of going through all the process. 2 comments to make. As you have rightly pointed out, I also agree that the proximal M2 is not a MEVO. I think when we are thinking about MEVO, Dr. Satya is also working in our institute. What is most important is we are very skeptical about taking the M3s and
Yes.
P3s, and so those are not a group for us, because as you know, they present with minimal deficit. We still do not know whether they benefit, but probably there is still in them a select group where, that is why these studies have become negative. We need to do a subgroup analysis, and I'm sure there will be papers coming out on that, to see in that group which would be the best patients who are likely to benefit. And once you have better stent retrievers or better smaller devices which can go through it, because everybody is worried about the perforation and producing more harm. The major problem is all these are minor strokes, so you do not want to produce any harm, and we want to do the best for the patient. So I think the message is very clear. Any comments?
I agree with that. It's the technologies which is going to make a difference. It's the concept is good. It's the technology that need to stand up to that. Good presentation.
Thank you.